We have questions for everyone. So, okay. We have a question that says, my husband is African British and has been diagnosed with a plasmacytoma December 2018, which is affecting his right femur, required surgery. There's no evidence of disease elsewhere, but imaging in 2020 shows that it's now 2 breastbone, in the sternum area, 2 lesions, fulfilling the diagnosis of myeloma. So, is this myeloma or multiple plasmacytomas and concerns, but the blood and bone marrow are normal. So more of a treatment question.
So I would say you need to have bone marrows, you need flow cytometry, these are the cases where you really need to make a diagnosis of whether the disease is disseminated or localized. And if there's any suggestion of dissemination, you need to treat as a disseminated disease.
Okay. Yeah, and that does happen from time to time, that people have bone-only disease where really the bone marrow is negative. So that is something where people have, if those areas of the bone are biopsy proven to be plasmacytomas, if you have multiple plasmacytomas all over, even without bone marrow involvement, you still can have multiple myeloma.
Mm-hmm. Okay, another question of vitamin D insufficiency is more prevalent among African Americans. Has this been studied? With respect to myeloma also being more prevalent among African Americans? Very interesting question.
It's a hugely interesting question, and it's a very great point, but I don't think there's been any work on it that I'm aware of.
It's not that hard to ask for vitamin D. I started asking my doctor to run that panel during COVID because I was super curious to see, right? And that goes to, like Dr. Bauer's point, that the more data you have and the more robust your data, and to all your points, we should probably start asking this question.
We are starting to analyze vitamin D levels just because there's a lack of information. It can be something as simple as from the serum. But there's the opportunity to look at it in some population-based data sets like the National Health and Nutrition Examination Survey. It can be hard to look at vitamin D without other confounders or things that might be related to vitamin D levels, but like sun exposure and the outcome, like somebody's exercise, somebody's lifestyle habits. We know that vitamin D is correlated with melatonin in the skin, and so thinking about these types of studies with a complete picture about somebody at the macro level, I think is really important.
Any other comments about vitamin D?
Yeah, I'll just say that, really on a generalizable statement, it's unknown. There's been these small studies and things that show that maybe it has an effect or on outcomes and some of those kind of things, but really to say that it's kind of a blanket statement, we don't really know. Again, as we talked about before, because of the rarity of the disease, because of the lack of really kind of getting all the data to talk together, meaning that, in sunny Florida, maybe that's different than what's happening in Boston or some of those kind of things. And so we really haven't connected, unfortunately, the pieces of the dots to make a statement like that to be as fruitful as someone would hope.
Mm-hmm. There was my husband doing work with the Caribbean also, and they are calling COVID kind of a rich person's disease, interestingly enough, because they're not having as high a prevalence in the Caribbean as other countries. So that vitamin D connection would be interesting to look at in myeloma. Anietta is asking a question. She says, I'm a 65-year-old Black female diagnosed with smoldering myeloma in 2015 that was recognized on lupus lab work. No treatment until 2019 with the myeloma, has severe peripheral neuropathy with Velcade, and wants to know, is on now Darzalex. So what about the prevalence of peripheral neuropathy in the Black population? Is there a significant selection of drugs to use in this population, either to prevent neuropathy, or are there any treatment changes, I think is what she's asking too, that you think about when you're treating Black patients?
With respect to neuropathy and bortezomib, there's really very, very scant data. I'm aware of one abstract out there on neuropathy in Black patients. That's really all there is. But it is an excellent question for the reason that we know the way bortezomib is metabolized is through a group of enzymes in the liver called cytochrome P450 enzymes. And they are highly polymorphic enzymes, meaning in different racial groups, there can be different activity, there can be different genetic makeup and different activity of those enzymes. So this is completely understudied and needs to be looked into. And again, goes to the point that several people have made about enrollment in trials being diverse, because if those patients are not enrolled in study, we just haven't got that information.
Okay. Anybody else commenting on that? Okay, another question was, I was reading that myeloma tends to present at a younger age in the African-American population, tends to be less aggressive. Any reasons for this that you're aware of? Which kind of goes back to the clinical trial idea. So if you're running trials, you need to be able to look at these types of data points and population subgroups. So assuming that these characteristics are true, and assuming that access to effective therapy is unhindered, do African Americans tend to have better survival rates in myeloma?
I guess I'll start. So it depends on what data you look at. When you look at kind of cancer registry data, data that's reported from cancer registry. So there's a couple different ways to measure clinical outcomes or long-term outcomes. There's survival rate, which is kind of defined from the time of diagnosis and until the date of death. In general, in cancer registry data, survival trends are somewhat similar, although as Dr. Patel had mentioned, when you look at populations, basically when in situations where treatment or access to treatment is standardized in a population, like in the setting of a clinical trial or in populations with individuals in the same healthcare system, there is data that's suggesting that Black myeloma patients have better survival than white and non-minority patients. So they have the opportunity to experience better survival in theory, but they often don't, because there are differences that we're talking about right now in access to care and healthcare utilization. I think another important statistic to consider just in talking about disparities is mortality rate, which is different than survival rate. So mortality is a metric that's defined as the number of deaths in the US per year due to myeloma. And we care about mortality rate because it's a metric that's driven by how many people are diagnosed each year with myeloma. And so it's very much driven by the incidence of the cancer. And so in contrast to some of the observations that we see in myeloma survival, where at least in an equal care setting, Black or African-American patients are doing as well or potentially better, we still see that Black patients, Black individuals are dying from myeloma about twice as high of a rate as white and non-minority patients. And this is because they're being diagnosed at a higher rate. And so I think there needs to be a lot that we still need to do to understand why myeloma occurs more frequently in Black individuals and understand how we might be able to prevent its onset, because a huge portion of the disparity in mortality is driven by the fact that it's occurring more frequently in Black patients.
Okay.
I would just add, I think one other area that I think we could really improve upon and sort of goes back to my comments is that I think one of the areas is that, yes, we have these, some data on overall survival, we have some data on mortality, et cetera. I think one of the areas that we're really lacking personally is just a lot of information on specific response to a specific therapy. What therapy is best for an African-American patient. In many of the trials that we see, there may be some differences, but the problem is there's too few patients to really know if that difference is real or not. Unfortunately, I feel like we often don't get back to that question or don't have enough information to really answer that. And I think that actually has a really large potential to have a huge impact. So I guess that would be one thing that I would argue that we should really look more at and make sure that we're you know, giving the best possible treatments for each patient individually.
You know, I just want to say something real quick on that, Nicole. We actually are doing something like that here in Tampa, not to toot our own horn a little bit, but we have basically, and it's not prime time yet, but from a research standpoint, what we're doing is taking all our patients and basically trying to figure out on a personalized basis which drugs work best for this person. And so it's coming down, expect something very soon, but that is something that we will likely be answering because we're already doing it and it's showing great promise. Because there's some people for common drugs like, you know, Revlimid, which literally should be in the water for somebody with myeloma, that really be showing some people it shows resistance to. So now if that's given at front line, now unfortunately you're taking somebody who's disease, who's already kind of at its peak and it's not even making a dent. And so if we can know that up front, that saves the patient's time, money, and effort. And so I don't know, just, you know, we're doing some things here at Moffitt to really change that.
Great. I think that's somewhere where HealthTree could help out as well. Like we'll be running a genomic study to try to ask those same questions, like who's getting the best outcomes with what genetics. And you could do that as part of that study or do a whole separate study using real world data because we have real world data and we have African Americans here who are participating. I love that you're doing that study at Moffitt. So awesome. Okay. Yafet is asking Dr. Marinak, was the 3% of individuals over 50 with myeloma for the general population? And then he just wants to thank you for your work on the PROMISE study.
Yeah, so the 3% is the general population. What's unfortunate is a lot of these data that we know with respect to the descriptive epidemiology of myeloma precursor condition has come from a population in Minnesota, which is predominantly white. We have evidence, you know, both from other studies as well as we're gaining from the PROMISE study that the percentage of individuals who are Black or African American who test positive are much higher. So we generally think of the prevalence of MGUS in the population to be 6 or more percent. We're getting a little bit higher in the PROMISE study. Interestingly, because a lot of our Black and African American patients who are screening also have a strong family history, so have multiple risk factors. So that's something that as we continue to collect data, we can dig into further.
Okay, great. Thank you so much. Okay, there's another question. LaRonda is asking Dr. Morgan, you referred to some score like an admixture score or whatnot. Can you explain that a little bit more?
Admixture scores. So they allow you, so, you know, 23andMe and those other scores that are done, that you take some of your DNA, put it in the post, and then the company will say, where is it that your genes come from? And they show either kind of Ireland, England, Central Europe, or they show the Horn of Africa or kind of Central South Africa. And those are really called admixture scores, and they tell you from which population you're drawn and how related or not you are to people around you. And so if you apply those scores to a US population, you see something like Brandon said about like there are people from Nigeria, there are people from the Congo, but there's an admixture with the kind of populations that are also seen in the US, the white population, Native American, and the kind of, for better words, South American and Latino populations.
Mm-hmm.
I think that helps you get past just the labels, because like even me being half Black, half white, like if I mostly say that I'm African American, where do I lie if I was just being categorized? But when you have something that's more concrete and isn't just by my own feeling of what I am, you can get at what might be better for me or my people that are similar genetically to me in that way.
Mm-hmm. Yeah, and more data. Yeah, you have more data points to look at and review. Maddie is asking a question about inclusion in activities and education and things like that. And Dr. Patel, you kind of said, you know, we own a lot of the responsibility, but as a patient advocate, I may disagree with you a little bit on that, because patients, it doesn't seem fair as a patient that you have to self-advocate, but I think more is being asked of you as a provider than ever before. And some of the questions, one of the questions was like, gosh, sometimes my doctor doesn't spend enough time with me. That's very common for any patient of any background, right? Because you're just being asked to do so much more. So it doesn't seem fair as patients that we might have to do this, but we have to self-advocate. We have to empower ourselves. We have to seek out education. We have to go to meetings. We have to watch things like this and educate ourselves about what's happening in myeloma. So I don't think the burden of responsibility is completely on you, because we have to decide that we're going to join clinical trials and be willing to do that so that we can contribute. It is in our self-interest to do that. Yes, it needs to be a trusted relationship, but her question is, you know, they restarted their outreach efforts in Philadelphia, so large African American community. They reach out to cancer centers, primary care doctors, churches, Black medical associations, and they've been having a harder time attracting more African Americans in the group. And they have very valuable information to share around treatment options, financial assistance, clinical trials. So does the panel have any suggestions for a group like this that's providing great info and wants to serve? Like, we're here to serve. Same thing with us. Like, we want everybody to benefit from all of these programs and the education that we provide.
Yeah. So I think you make a very good point, and I think that's part of what is pretty cool about treating this disease, is that there are amazing patient advocacy organizations, right? Like yours. So I think you're absolutely right. We come across this problem actually pretty commonly. So I think there's desire here from both sides. So I have a good patient / friend listening to this right now who felt exactly the same problem from the opposite side. She said, well, look, I want to be able to get these resources. I want to help other people. I want to start a support group because, you know, my friends might not feel welcome at other support groups. They're not based in our hospital, not based where we're comfortable. And for sure, there's a role to help people, I think, advocate for themselves. I think you have to accept that sometimes people want to start up their own group and they want to get education in their own community. And I think there's definitely ways of helping to do that. So she's had help from some of the national organizations to set up her own support group. And I think that she feels that this is a much more comfortable space for her to bring her friends and people she's met in clinic in to discuss issues that they experience. So I would say to the person who's saying, hey, I want to engage, yeah, absolutely, you can help. I think you might also have to help people in their community where they're comfortable.
Mm-hmm. Right. And it's a long-term relationship as well. So you're building a long-term friendship, and then you can offer things that might be helpful and with that relationship. So there's a question about, are there any studies about the history of a person's exposure to chemicals, like employment history and industries, statistical differences between Blacks and whites when you look at environmental type issues? Any thoughts on that?
There's barely any good information on environmental exposures. There's a lot of studies, but so petrochemicals is a great example. When you come down to how many people were actually exposed or not exposed and got it, it's in the teens rather than even hundreds. And so, yeah, no, there's no real good information on that.
Mm-hmm. Yeah.
I will say that some people didn't know about the Agent Orange and the veterans exposure too. So, you know, if there's anybody who's listening who has a loved one, or you might have been a part of Vietnam, the VA does offer benefits and those kind of things who carry a diagnosis of multiple myeloma. Not only benefits for you, but benefits upon death and some of those kind of things sometimes, which can really be important. So if you're connected to the VA system and we're exposed to Agent Orange, you might want to reach out to the VA system.
Mm-hmm. Okay, good point. Evelyn's asking, are there physical specifics in African American multiple myeloma patients that would prohibit a successful stem cell transplant? And are there viable and affordable regimens to access if patients do not receive a stem cell transplant? Can we address the idea of stem cell transplant in the African American community also? Because I know there's lower utilization of stem cell transplant for this group, and that's one of the most effective and upfront therapies that typically patients receive.
So the data on transplants that we have from the CIBMT, or Center for International Blood and Marrow Transplant Research, shows that African American patients get to transplant at a lower rate, they get to transplant later, and when they get to transplant, they've had less effective induction therapy. And that I'm aware of, there's no medical reason why a transplant shouldn't be done. So we're talking about access to care issues here.
Okay, anybody else?
Yeah, I think also too, some of these things are super complex, and so I think having a diagnosis of myeloma, talking about plasma cells is already kind of complex enough. Now you're saying you want to do stem cell transplant. So I think sometimes, and I'm not sure if there's data on this or not, but it's like, are some people not even getting the referrals to a major transplant center like here, are people in the community who are receiving most of their treatment just saying, nah, I never heard of that, not really sure what that is, I'll pass, because, we have some data here internally that once people get the BMT consult, there's no difference, but it's basically how do we get people in the door, and so I think, it's kind of it's a tough question because while we would love to treat every person in Florida, it's not logistically possible, and so people wouldn't drive hours down the road to come see us when they can go 10-15 minutes down the road to the local cancer doctor. And so I think that might be some of the issues, and so we're actually doing some studies to try to see if we can identify some of those kind of questions, and kind of, is it an understanding of the oncologist, is it a lack of is it a bias from the local oncologist trying to say like, hey, I don't think this person is a good fit for training, so, because some of those things also play a matter, because it's hard for someone to get to a specialist like me if they never can get the referral in the door, and so sometimes that does play an extra layer of complexity. So it's like it's like an onion, that the layers and complexity is just kind of, it's not one answer.
Right, and we always stress to myeloma patients, just because your first treatment is so critical and your treatments at relapse are so critical, do whatever is possible to see a myeloma specialist, especially when you're making these treatment decisions, because you will be exposed to things like this, like to talk about stem cell transplant, why you should do it now versus later. Like, you need to have those important conversations with your doctor. And so we try to go direct to the patient to say, like, that's really important. There's data that shows you will live longer if you see a myeloma specialist. And that's both from the Mayo Clinic and the University of North Carolina. And it's real, and that needs to happen. So we recommend that all the time.
That's why I think your patient empowerment thing becomes really important, because, however much we might think we're impartial as medics, there are factors that play out that mean we are not and never can be impartial. And so for patients to mandate that seeking out a good opinion initially is really, really important. It's one of the major messages I think you give to people.
Mm-hmm. Well, because it's needed. Oh my. And you just feel exhausted as a patient, like, oh my gosh, I have to do one more thing for myself. But you do, like, that's my message. We just have to kind of get over that idea that we can't do it. Like, we can, and in that entry video, Cindy talked about how she just kind of, took doctors' recommendations, and then she became an advocate. And she's helped us create HealthTree University, which is this huge online curriculum now with 93 myeloma experts teaching in the curriculum. And you could actually just binge watch your way through that if you wanted to do that, to learn about myeloma. Okay, Marianne has a good question. She understands the genetic side of it, but what can, and we've all talked about this as a larger issue, the socioeconomic disparities, whether it's travel or access or Wi-Fi, and those are very real practical things and challenges. So is there anything that institutions can do who are treating patients to help overcome those things? And then I would ask the question, is there anything we can help with as a patient advocate organization? Any thoughts on that? Tough question, right? Because it's so broad.
That is a really tough question.
Mm-hmm.
I think institutions, in general, most large institutions try their best to help with these issues, right? There's many institutions have internal resources, whether they're financial, educational. There are a lot of great organizations out there that assist patients, not just with education, but also with just resources, right? Money, just giving people things like copay assistance, travel assistance. So I think oftentimes it can be tough to navigate and figure out those issues and where to get the help. You know, it's always heartbreaking when you hear that patients come to you and say, well, I paid XYZ for my copay, and you think, wow, there was a resource. You didn't need to have made a decision between paying that bill and paying for copay assistance. So I think organizations like your own are really important in helping to fill that gap. But sometimes if you speak to your healthcare team, the physicians you're seeing, social workers you're seeing, they'll have access to other resources that they can help in terms of just practical things, lodging, travel, things like that.
Mm-hmm. So speak up and ask, right? About what might be available. I think our last question, we're out of time, but so she says, I'm a 36-year-old African-American female diagnosed with MGUS with a recent MRI showing a hole in L4 causing unimaginable back pain. Specialist wants to do a bone marrow biopsy with no sedation. How do I advocate? So this is I did this in my clinic too. After the first time getting a bone marrow biopsy with no sedation, I just said, I'm not doing another one if it's not with sedation. So we need to make that happen. I know that can't happen everywhere, but so at some point you kind of have to speak up, because you can develop, I don't know, PTSD reactions, and you're going to have to get bone marrow biopsies for a considerable amount of time. So I don't know, from a medical professional suggestion about that question, but I would try to push a little harder.
I turn the question around a little because I think the appropriate advice is you need to take this really very seriously. The clinical situation you're in kind of is really pointing you to needing treatment soon, and not to go round and round the bush with this. They either need to offer you a bone marrow quickly or go somewhere else where they will offer you. I mean, it's a bit harsh, but it's such an important thing not to wait and wait and wait.
Yeah.
Yeah, sometimes I know some places just logistically can't do it, because sometimes when you do it under the anesthesia or what they call conscious sedations, it requires a lot of monitoring. So depending on the place that you're in vicinity to, they may just not have the staff or the resources to do something like that. Typically, the bigger places, I know here at Moffitt, we do put people under conscious sedation, and people are, kind of out during the bone marrow biopsy procedures. But I doubt that the doctors won't do it. It just may be a policy issue, that maybe sometimes under like the what they call healthcare administration, or the people who kind of make sometimes the decisions for the doctors, unfortunately. So I know it's kind of an unfortunate situation, but there are some places to do it. I'm not sure if you're able to kind of travel to other places to kind of get it. They can maybe share the pathology report or what they found, but really sometimes it's more of a logistical issue that just unfortunately may just be manpower.
Yeah, good point. Yeah. Okay, well, we are out of time, but what I would like to do is thank all of you for an amazing panel. We talked about a lot of things today that are important to all patients, and especially the African American community in the United States and elsewhere. So thank you to you all for participating, for sharing your expertise. You each touched on such an important different aspect of things. I would encourage patients to join the PROMISE study, to consult with a myeloma specialist, and we will continue to advocate for you. Greg, did you have any final comments?
No, I just want to thank everybody. This was a truly wonderful meeting, and I'm so happy that we had it. And this is the first step in a long journey. We'll be back on this topic, and we'll be back with many of you, if not all of you, in the future. Thank you.
Thanks for joining, everybody. Take care.
Thanks a lot. Goodbye.